looks like it's pretty steady. All right. Okay, so welcome to our education session this evening. I'm Jo Silver. I'm the GP advisor at Western Health. And behind the scenes from PHN, we have Yvonne, who's done lots of work drawing all of this session together for us. Our presenters this evening are Stav Papastolou, I always have trouble, who's one of the cardiologists from Western Health, and Carice Brown, who's our heart failure nurse from Western Health. So I'll begin this session with our acknowledgement of country. Next slide, Stav. Stav's driving the slides tonight. So Western Health and Northwest Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woiwurrung people, the Boonwurrung people and the Wattarong people. We pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Next slide. So the usual housekeeping with all of these sessions, because it all gets a bit complicated online. Everybody is muted. If you could just ensure that you ask your questions in the Q&A box, because I have trouble keeping across multiple things. So put the questions in there. The session is being recorded and you will receive a link to the recording with the post-session sort of correspondence and all the resources that Stav has for us. So Yvonne will send those out in the next couple of days. Next slide, oops. Just back one. I don't know if we can go back. So if people can just check that the name that they've joined with for the session, next slide, I think, Stav. Yep, the next, if you could just ensure that the name that's showing on your screen for yourself is the name that you've registered with, and not your child's iPhone or iPad or something like that. If you're not sure, please send Yvonne a message in the chat function. Just tell her who you are, so she can ensure that she marks your attendance for your CPD, and we'll send out your certificate. Right, next slide. So as with all these sessions, we like to give you a bit of an update on Health Pathways Melbourne and how you can find some information when you're seeing patients in the room or you're not sure about management after this session and you need to go looking around. So there's a Health Pathways section on heart failure. Next slide, Stav. So as you know, these pathways are written by GPs with who are clinical editors and with support from local GPs, hospital-based specialists and other subject matter experts. They provide you with evidence-based advice. They opportunity to reduce variation in care. They tell you how to refer into the various hospitals and community services and find what services are available for your patient in your area. So if you click on the Western Health one, it'll take you into our referral guidelines to support you to ensure that you provide that right, all the information we need to triage your referral. Next slide. So this is the where you can find the Health Pathways heart failure, and you can see that there's lots of different things that you can look for around that work your way through that. If you have any issues or you find something that you think, oh, I need to get them to add that in or make a change, please send some feedback because they always want to keep these as current and up to date for GPs. And next slide, Stav. So this is the heart failure page where you can go through, find the important issues, things to look for when you're assessing the patient, the red flags, and then click on through appropriate investigations. Next page. Helps you with management. So things to look for, things that you can do, medication updates, how to manage your ongoing management, exacerbations, and if, you know, support with care after they may have been in hospital and discharge and how to manage them, titrating up medication, and also reaching out for help if you have any concerns. Next slide. And this has got the, if you want to do a referral, so the how to do the referral into the hospital services. I know some hospitals have various templates and things. At Western, we're very happy for you to send it on one of your practice letterheads, and just make sure you've checked to ensure that you're providing all the investigations that we need to triage that. Thanks, Stav. Next slide. And this is all the different cardiology pathways that are available. So lots of information there. And the other thing is, if you spend some time working your way through the pathways, you can log some CPD hours. So you used to have to self-log, but now you can click on the CPD hours, and that will link through and just log the time that you've spent. So that's quite helpful for us as well, because we're sort of coming up to the end of having to make sure we've met all our education requirements. So next slide. So most people will have been registered for health pathways. They've now gone from the generic login to individualized logins. So if you don't have access, or you're not sure if you have access, then please email to the Health Pathways team. You can scan the QR code there, and they will provide you with your login. Next slide. And Health Pathways also send out a bulletin, so if there's any updates, new pathways, you will receive the bulletin and all the current changes. So you can sign up for that bulletin as well as the PHN newsletter. Next slide. All right, so our speaker this evening is Stav Papapostolou. So Stav is a cardiologist at Western Health, and she is the clinical lead for our Western Heart Failure Service. So she has special interests in heart failure management and advanced cardiac imaging, including echo, coronary CT, and transesophageal echocardiography. She's completed the majority of advanced cardiology training at the Alfred, followed by a non-invasive cardiac imaging fellowship at Monash Health, and she holds a PhD from Alfred Health, where her research focused on novel applications of cardiac MRI. Yeah. Over to Steph, and I'll mute myself. So we'll try and manage the questions at the end of the session, but if there's anything pressing, we'll interrupt Stav as we go along.
Okay, thanks, Jo. Hi, everybody, and thank you for coming along tonight. So my name is Stav. I'm one of the cardiologists at the Western, and today I'll be giving you a brief overview of heart failure management in the community. And one of our heart failure nurse practitioner candidates, Caris Brown, is also here with us today, who will give us a little bit of information at the end of one of a research project that we're running at the Western. All right, so our aims tonight are to improve our understanding of heart failure management, and to think about when and how to refer for specialist input. We're going to go through how patients with heart failure are managed after they've been discharged from a hospital admission, mainly focusing on the heart failure medications and how to safely uptitrate those in the community post-discharge and also in between visits with their cardiologist. We'll talk about deprescribing of potentially harmful medications, how to construct flexible diuretic plans for our heart failure patients, and then we'll talk very briefly about other community services and heart failure nurses' cardiac rehabilitation. We'll focus a lot on the difference between the different types of heart failure, mainly dividing heart failure into heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, and discussing the different medications and management strategies we use. And we'll also briefly touch on focusing on the comorbidities and treating the comorbidities that are often seen in our heart failure patients and can potentially worsen heart failure, such as sleep apnea, obesity, and atrial fibrillation. So we'll talk about what is heart failure, the causes and precipitants of heart failure, how to diagnose it, how to manage a patient after they've been discharged from hospital, how to uptitrate their therapies and treat their comorbidities, and referring on to cardiology and to community services. And as I said at the end, our heart failure nurse practitioner, Karis, will go through a project that we are involved in at Western Health called the Safe HF project. And we would really love to have input from GPs as well for this project. So we'll start off with talking about what is heart failure. So heart failure is a complex clinical syndrome where there are symptoms and signs that result from either structural or functional impairment of the ventricle's ability to eject blood, which is systolic dysfunction, or the ventricle's ability to fill with blood, which is diastolic dysfunction. So either due to systolic or diastolic dysfunction, the heart's not able to pump enough blood to meet the body's demands while maintaining normal left ventricular filling pressures. Now, it's usually not just one or the other. All patients with systolic dysfunction have some degree of diastolic dysfunction, and patients that have heart failure with preserved ejection fraction, which is predominantly diastolic heart failure, also have subtle features of systolic dysfunction. Now, it's important to know about heart failure because it's quite common, especially because of our aging population. And heart failure does carry a high morbidity and mortality, and there's a high risk of hospital readmissions once a patient's had an admission for heart failure, and that's about 25% in the first 30 days post-hospitalization. And it does carry a poor prognosis and often carries a poorer long-term prognosis than many cancers. And it's important to get patients on the right therapy as well, as we know that guideline-directed medical therapy has been shown to reduce hospitalizations, improve morbidity, and improve mortality. Now, there are different ways of classifying heart failure, but we tend to divide heart failure up based on ejection fraction. So we have heart failure with reduced ejection fraction. These are patients that have heart failure and ejection fraction that's less than 40%. And in this group of patients, we have very good evidence that guideline-directed medical therapy improves morbidity and mortality. Then we have a group of patients that fall somewhere in the middle, and that's heart failure with mildly reduced ejection fraction, where the EF is somewhere between 40 to 50%. And in this cohort of patients, there's somewhat less evidence for guideline-directed medical therapy. Phenotypically, these patients kind of present more like the standard HFrEF patients as opposed to patients with HFpEF in terms of how they present clinically, the phenotype, and their management. Then we have this third group called HFpEF, or heart failure with preserved ejection fraction, which we used to call diastolic heart failure. Now, the word HFpEF refers to a very particular clinical syndrome where the ejection fraction is normal, so it's more than 50%. However, there is evidence of elevated left ventricular filling pressures either at rest or with stress. However, in order to classify as HFpEF, they also must have symptoms and signs of heart failure. Now, there's less evidence for medicines that help to reduce mortality in this cohort. And the focus of our treatment in the HFpEF cohort is aimed at treating decongestion, controlling contributing factors, and also treating other conditions that often go hand in hand. Now, this very simple classification doesn't really cover other things that can lead to heart failure, such as valve disease, ischemia, tachyarrhythmias, bradyarrhythmias, or the cardiomyopathies like infiltrative cardiomyopathies like amyloid or restrictive cardiomyopathy, hypertrophic, non-compaction, ARVC, etc. And these often have their own specific therapies. Now, if a patient presents with heart failure, we need to think about what the precipitant may have been of an acute decompensation. Now, this is a mnemonic I've used for a long time now, which is Mad Hatters. And I always think about all of these things when I see a patient that's been admitted to hospital with acutely decompensated heart failure. So the M stands for MI or ischemia, A for arrhythmia, D for drug or fluid restriction non-compliance, H for hypertension, anemia, thyrotoxicosis, infection or fever. The E stands for ethanol, as alcohol can be a common cause of heart failure. And in that group, I also class other drugs that can lead to heart failure, such as amphetamines, methamphetamines. There are other drugs as well we need to consider: chemotherapeutic agents, non-steroidal agents, and certain calcium channel blockers like verapamil and diltiazem. The R stands for renal failure and S for sleep apnea. So if we're seeing a patient for the first time and we suspect they have heart failure, we need to go through the normal process of history, examination, investigations. So in history, things that might point to signs of left heart failure include breathlessness on exertion, fatigue, a cough that might get worse when they're lying flat, orthopnea, P&D, weight gain. And some things that might point to right heart failure again include shortness of breath on exertion, peripheral edema, ascites, a loss of appetite, and nausea. On examination, we would look at things like their JVP, assess their lungs for any evidence of fluid overload, either effusions or edema, assess their heart sounds for any murmurs, assess for any peripheral edema or ascites, and very important on examination to assess if they're getting adequate perfusion, if their blood pressure is normal, and they're not cold or shut down. So the investigations that we might do in a patient that is presenting with something that we think is heart failure includes an ECG. That might allude to the underlying cause of the heart failure. So we might see ischemic changes that might point to an ischemic cause for their heart failure. They might demonstrate an arrhythmia or atrial fibrillation, or very commonly in patients with heart failure with reduced ejection fraction, they might just have a left bundle branch block. The blood test will just do a standard panel, usually of blood tests, hemoglobin to look for anemia that might contribute, their thyroid function tests, troponins if we think that ischemia is a cause, iron studies as making sure people are iron replete is important in heart failure as well. BMP is something that can be done. However, I find it more useful as a rule-out test. So if it is really low, then that makes heart failure less likely. If it's very elevated, that might point to heart failure. But when it falls somewhere in the middle range, then it usually isn't all that helpful. And we need to keep in mind that it can be influenced by other things. So it can be reduced in obesity, or it may be elevated in chronic kidney disease or liver failure or sepsis. We would also go on to do a chest X-ray, looking for cardiomegaly or features of overload. But most importantly, as cardiologists, we like to order echoes. Now, the echo is important in heart failure patients because it will help us determine what kind of heart failure the person has. Is it heart failure with reduced ejection fraction, for example? It will also give us some assessment of their diastology, and that might help point towards a diagnosis of heart failure with preserved ejection fraction. It might demonstrate regional wall motion abnormalities that would point to ischemia as an underlying cause, or there might be valve abnormalities, or there might be other findings that point to a specific diagnosis, such as amyloid or hypertrophic cardiomyopathy, etc. Now, when I'm seeing a patient in hospital and they've come in with heart failure, we are generally focused on getting them decongested or dry. So what we would normally do is aim to diurese them, and that usually involves Lasix, putting them on a fluid restriction, usually about 1.5 litres per day, and aiming to get, whilst they're in hospital, about 1 litre off per day. At the same time, we would also investigate and treat for any potential precipitants, such as ischemia, arrhythmias, a coexisting infection. And if it's a new diagnosis of heart failure, ruling out coronary disease, either with an invasive angiogram or a CTCA, is quite important. Also in hospital, we use that as an opportunity to get started on guideline-directed medical therapy. And the guideline-directed medical therapy varies depending on what kind of heart failure the person has. And we will go into that into a little bit more detail. But in heart failure with reduced ejection fraction, so that's those patients that have an EF of 40% or less, we have pretty good evidence for the use of the 4 pillars. The first pillar involves ARNIs, such as Entresto, ACE inhibitors, or angiotensin receptor blockers. Secondly, the beta blockers. Third, mineralocorticoid receptor antagonists, such as spironolactone, and then our SGLT2 inhibitors. And also, we tend to wait to start the beta blockers once the patient is euvolemic, in particular in those patients that have a new diagnosis of quite severe heart failure. For those patients with the mildly reduced ejection fraction, we don't quite have the same evidence for the 4 pillars, and treatment is focused on ACE inhibitors, angiotensin receptor blockers, beta blockers, and spironolactone. And for heart failure with preserved ejection fraction, there is some evidence for SGLT2 inhibitors, spironolactone, but mainly the focus is on trying to improve their symptoms, decongestion, and treating their comorbidities. So that's what we tend to do in hospital. And then when we discharge patients, we would ideally like patients to be seen within a week by their GP. And that's to make sure that everything is on track for a fluid review to ensure that they are euvolemic or the diuresis is continuing gradually. We also would like to check their renal function at that time, because all those medications that we start them on, either the diuresis or the guideline-directed medical therapy, can affect the kidney function. So we want to make sure that their renal function hasn't deteriorated by more than 25%. And we would also like at that review to have uptitration of those guideline-directed medical therapies, because we know that by uptitrating therapy, we're more likely to get an improvement in morbidity and mortality. And the uptitration of medication is really guided by how the patient is feeling, their symptoms. We want to make sure they're not feeling dizzy on all these new therapies, that their blood pressure and heart rate is adequate to allow further uptitration, and their kidney function allows. Now, a lot of hospitals, including at the Western, we might have a RACER clinic, so a rapid access clinic. And we do try to get most of our patients seen in RACER clinic, but unfortunately we can't accommodate all of them. And so particularly in those that we can't get a RACER clinic appointment, we really do like them to see their GP early for that fluid review, blood pressure, renal function testing, and uptitration of medications. Next, we'll go through some of the medications that we use in heart failure. Heart failure with reduced ejection fraction is the main focus, but we'll also talk about HFpEF. And all the medications that we use come from a whole heap of trials that demonstrate mortality or morbidity benefit. And we've already said that there are 4 main classes of drugs in HFrEF, so ejection fraction less than 40%, that have been shown to improve mortality. The first class is the ACE inhibitors, the ARNIs, angiotensin receptor blockers, the heart failure selective beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. There are other medications that we use in patients with HFrEF, but they haven't necessarily been shown to reduce mortality. So for diuresis, we use Lasix or furosemide, and we can sometimes use bumetanide, especially when a patient is becoming less responsive to furosemide. These diuretics don't really have any mortality benefit, and the role of these is for symptom benefit and for decongestion. Other medications we might use in our heart failure population include digoxin. Again, no mortality benefit in the trials, but some evidence that they might reduce hospitalizations in our heart failure population. And then there are other medications like ivabradine and nitrates. And when we're prescribing these medications, we really should take into consideration the patient's individual circumstances. Now, if we are seeing a patient with a new diagnosis of heart failure and they are naive to all heart failure medications and their ejection fraction is really quite severely reduced, we need to be quite cautious and careful with the introduction of heart failure therapies, and in particular with the beta blockers. So in those patients that have really terrible ejection fractions, we need to make sure that we do careful diuresis, get them euvolemic, and then cautiously introduce those medications, because patients that have an EF of about 20%, especially if they're medication naive, they may be hypotensive at baseline, so we need to really do it carefully. So the first pillar of medications that we use in our HFrEF cohort include the ARNIs, ACE inhibitors, and ARBs. Now, ARNIs are relatively new. They've only been around, I think, for about 8 years, maybe. And it's Entresto. And that usually is the first line medication we tend to use now for patients with ejection fraction less than 40%. And then we have our ACE inhibitors such as perindopril, ramipril, and our angiotensin receptor blockers as well, candesartan and valsartan. So how do we start Entresto? So Entresto can be started and is on the PBS for those patients that have an ejection fraction that's less than 40%. Now, if the patient has already been on an ACE inhibitor or an angiotensin receptor blocker, we do still try to get them onto Entresto. But when we're swapping them from ACE inhibitor or angiotensin receptor blocker to Entresto, we need a good 36-hour period to allow those medications to wash out before starting Entresto, because otherwise there is a higher risk of an adverse reaction and angioedema. Now, there have been many trials now that have shown that Entresto has a mortality benefit over ACE inhibitors and work to reduce hospitalizations and improve morbidity. So if we have a patient with a new diagnosis of heart failure and we're diuresing them and we want to get them on guideline-directed medical therapy, Entresto, we can start that first up. But we just need to keep in mind that it may cause a little bit more symptomatic hypotension than we're used to with the ACE inhibitors or angiotensin receptor blockers. So we can usually cautiously start it if the blood pressure at baseline is more than 100, the patient's not dizzy, their renal function allows, so GFR more than 30, the potassium is normal. There are 3 doses of Entresto. So the starting dose is the 24/25 milligram dose BD. And then we can up-titrate that in a few weeks if the patient tolerates to the middle dose, which is 49/51 BD. And then we can further up-titrate that down the track to the target dose of 97/103 BD. So to qualify on the PBS, you need to have heart failure, you need to be symptomatic, an ejection fraction that's 40% or less. You can't at the same time be on an ACE inhibitor or an ARB. As we said, it increases the risk of adverse reactions and angioedema. And you must be on other heart failure therapy as well. Also need to keep in mind that we can't use it if the patient has had a previous angioedema reaction to ACE inhibitors or ARBs in the past. Now, when it comes to up-titrating Entresto in the community, we usually do it every couple of weeks or so as the patient can tolerate. The patient needs to have tolerated the dose, not be dizzy, a systolic blood pressure more than 100, renal function needs to have remained relatively stable, and the potassium less than 5. Now, often what we do in hospital when we've seen a patient for the first time with heart failure and we're starting them on their guideline-directed medical therapies, especially if they have quite severely reduced ejection fraction and therefore are not generating much of a blood pressure, they might be quite hypotensive at baseline, we might actually send them home on a very small dose of valsartan instead, which is a bit gentler, and with the aim of swapping them over to Entresto at the first review. We tend to choose valsartan in that situation because it means we don't need to wait for a 36-hour washout period. We can just get them onto the Entresto. Now, the second group is the ACE inhibitors that we use. So we're quite familiar with these because we've been using them for a very long time. So these include medications like perindopril and ramipril, starting doses of sometimes as low as 1.25 milligrams in those patients with quite severely reduced ejection fraction that don't have much blood pressure, with slow up titration, aiming to get up to the target dose of 10 milligram or whatever the patient tolerates. And again, the up titration guidelines are to make sure the patient has a blood pressure more than 100, they've tolerated the dose, the previous dose, they're not dizzy, their potassium remains less than 5, their renal function remains adequate. And every time we make changes to Entresto, ACE inhibitors, ARBs, etc., we should recheck their renal function and do a blood pressure check about a fortnight or so later. The third group that falls into class 1, the angiotensin receptor blockers, they include candesartan and valsartan, and the up titration guidelines is the same as for ACE inhibitors. Now, the second pillar of medications that we use in heart failure with reduced ejection fraction are heart failure selective beta blockers. We tend to not start them when the patient is quite overloaded and acutely decompensated, and like to get the patient a bit closer to dry before starting these. There are 4 to choose from: bisoprolol, carvedilol, metoprolol XL, and nebivolol. And the most commonly used, I guess, is bisoprolol and metoprolol XL. Now, the up titration guidelines for beta blockers, again, we need to make sure the patients tolerated the previous dose, the systolic blood pressure remains above 100, and their heart rate remains above 60 prior to up titrating. Now, there are different reasons that we might choose one beta blocker over the other. However, the most commonly used are bisoprolol and metoprolol. Carvedilol has BD dosing, which makes it somewhat less attractive, but it is thought to have some fewer metabolic side effects, therefore might be better in diabetic patients. There's some evidence it might be better in atrial fibrillation, and also because it's not as selective. There's some vasodilating properties as well, which may mean it's more preferred in patients that have peripheral vascular disease. Now, the third group of medications we try to get our heart failure with reduced ejection fraction on are the mineralocorticoid antagonists. So they include spironolactone and eplerenone. Spironolactone is the one we're probably most familiar with and we use more. The starting dose is 12.5 milligrams per day, and we generally try to get to a target of 50 milligrams per day. Eplerenone can also be used in heart failure with reduced ejection fraction, but it's only on the PBS for those patients that have a reduced ejection fraction post-MI, and it needs to be started within the first couple of weeks post-MI. Now, the up titration guidelines for spironolactone and eplerenone are similar to those for ACE inhibitors and Entresto. So the patient needs to have tolerated the previous dose, not dizzy, blood pressure remaining more than 100, potassium less than 5, their renal function remaining stable-ish, the creatinine not having risen by more than 25%. Now, we do tend to stop this if we're unable to keep a patient's potassium less than 5.5. So when we're starting spironolactone, I'm usually quite cautious and ask for a renal function to be checked again in 1 to 2 weeks to make sure creatinine and also the potassium remains relatively stable. And then check it monthly for the first 3 months, and then at least a couple times a year when the patient is on the medication long term. And if we're making any changes to the spironolactone dose, it's quite important that we recheck their renal function 1 to 2 weeks later again to ensure that their potassium stays within normal limits. Now, the final class of drugs that we used in the HFrEF group, SGLT2 inhibitors, so that's empagliflozin and dapagliflozin. Both of them are 10 milligrams per day for heart failure, and they're on the PBS for all heart failure patients, symptomatic heart failure patients. We need to keep in mind that they do have a mild diuretic effect. So if the patients are on other diuretics, that we might find that we need to adjust those with time. They also carry a risk or an increased risk of UTIs. So we need to counsel the patients about that and maybe avoid in patients that have had complicated or have frequent UTIs. We also need to counsel patients about withholding them on sick days because of the risk of euglycemic ketoacidosis. And they are absolutely contraindicated in our type 1 diabetics. So for our HFrEF patients in the community, we try to uptitrate medications, one medication at a time. Between cardiology visits and following discharge from hospital, we are often quite keen for further uptitration in the community, as long as blood pressure is adequate, as I said, and the patients have tolerated the medications that they're on. Now, a lot of our patients with quite advanced or severe heart failure with reduced ejection fraction might have a resting blood pressure of 90, let's say. Some have even lower blood pressures. And if that's their normal blood pressure for them, 90 is normal for them, you don't need to de-escalate their therapies if they're feeling okay on their current heart failure therapies. But at a blood pressure of 90, then that means we won't have any room to further up-titrate their heart failure therapies. Now, furosemide, as I said, doesn't carry a mortality benefit, but we use it to help patients feel better and decongest and get all that fluid off. And the aim after we have diuresed someone is to get them down to the lowest dose that they need in order to maintain euvolemia. And for our heart failure patients, we often also provide them with flexible diuretic plans, especially for those patients that have a good understanding of their disease. So we tell patients to keep an eye on their weights, and if their weights seem to be increasing, so it goes up a kilo one day and then it goes up another kilo the next day, then we might have given them some instructions to increase their Lasix or their furosemide for a short period of time and to ensure that they make a quick appointment to see their GP. So this is an example of a flexible diuretic plan that we might use. So let's say a patient is not normally on any furosemide and has a known diagnosis of heart failure. If they notice in the community that their weights are going up or they're starting to retain fluid, we might tell them to take either 20 or 40 milligrams and to ensure that they've made an appointment to see their GP within the 3 days. Or if they're normally on 40, we might tell them to take an extra tablet. If they're normally on 80, to go up to 120 for a short period of time, etc. Now, there are other medications or therapies that we use in those patients with an ejection fraction less than 40%. So ivabradine is one of them. And that can be used in patients where we might be limited to uptitrate those other heart failure therapies, where we might be limited by their blood pressure, because it has less of an effect on blood pressure. But in order for it to be effective, the patient needs to be in sinus rhythm. And you need to document their heart rate when starting it. So they need to have a heart rate in the 70s when you're starting ivabradine. And essentially it works to slow the heart rate down as long as the patient is in sinus rhythm. So that can be an additional useful medication to add on if we're limited by blood pressure. Digoxin is another medication and also nitrate. So isosorbate mononitrate can also be used sometimes in our heart failure population. There are other therapies that we might offer. So in patients with heart failure with reduced ejection fraction, we tend to try and get them on the 4 pillars of the guideline-directed medical therapy, and we try to get them on the maximum doses that they tolerate. And once they're on the maximum doses they tolerate, then we tend to wait a few months. 3 months is the guidelines, recheck their ejection fraction. If the ejection fraction remains quite low, less than 35%, then we might be discussing an ICD or a defibrillator in those patients. At that time, then we might also decide whether or not they would benefit from a bi-VICD, which would provide resynchronization therapy, and that would be offered in those patients that have had a good 3 months of treatment, remain symptomatic, their ejection fraction is less than 35%, and they've got a long QRS, and that resynchronization therapy might be useful for them. Other things we look at and we try to treat as well include their iron. So we tend to do that on discharge from hospital in our heart failure patients, and top them up with an iron infusion. And we counsel them about the importance of staying up to date with all of their vaccinations. So when we're sending patients home from hospital, and with every opportunity we have, either in clinic or embrace a clinic or with our heart failure nurses, we try to provide them with education about the condition, the importance of weighing themselves daily to keep an eye on their weights as an early sign that they might be retaining fluid, and when to seek help. So we've already said about those flexible diuretic plans. So if their weight's gone up by 1 kilo per day, 2 days in a row, that might be the time for them to use their flexible diuretic plan, and also make an appointment with their GP. We, you know, the evidence for fluid restrictions and low salt diets, that's sort of, there's not a huge amount of evidence, but we do still recommend fluid restriction, especially early on, low salt diets, and referrals to cardiac rehab are really important for ongoing education, and they help to improve patient outcomes as well. We counsel our patients about avoiding smoking and also illicit drugs, and we do have a huge amount of patients that have methamphetamine-induced cardiomyopathies and also alcohol-induced cardiomyopathies. So counseling about the importance of abstinence in those cases is vital. And we also need to treat the comorbidities that may worsen heart failure. So sleep apnea is quite common in our heart failure population, and we should investigate and treat for that, and treatment of any AF and obesity as well. Now, I've already kind of touched on how we should be quite cautious in the introduction of our therapies in a medication-naive patient with a new diagnosis of severe heart failure. So they probably already have a baseline hypotension, maybe a borderline sinus tachycardia. So in those patients, we really need to be very cautious. Diarrhea, and usually these patients will be in hospital anyway when we're doing these early medication changes, but diuresis them cautiously, and then very cautiously start our heart failure therapies. We also need to go through the medication lists and make sure we deprescribe any medications that might worsen fluid retention or worsen heart failure. So they include the NSAIDs, verapamil, diltiazem have a negative inotropic effect. So they should not be used in heart failure with reduced ejection fraction. And there are some other medications as well. So we've already gone through this. So we've seen so we've got a patient with heart failure, reduced ejection fraction. They're overloaded. We start with diuresing, and then the gradual uptitration or additions of guideline-directed medical therapies. Get them to the maximum tolerated doses, and then we tend to recheck their ejection fraction after 3 months to see whether or not we would be considering an ICD or CRT in those patients. So that's the first cohort of patients, HFrEF. That's probably the easiest in terms of medications, because it's quite clear cut. We have the 4 pillars of therapy that we try and get all our patients on, as long as their blood pressure allows and their renal function and heart rate allow. Now, the second group is that the second group that I'm just going to touch on is the heart failure with improved ejection fraction. So these are patients that previously had reduced ejection fraction, and now on therapy it has improved to either only mildly reduced or to completely normal levels. Even if this happens, we tend to continue them on their guideline-directed medical therapy, because there's quite strong evidence that relapse is common if we stop medication. So about 50% will relapse. Now, if we do decide, because the patient's quite keen to get off medications, to reduce or stop, then we need to do that quite carefully and monitor the patients for their symptoms, signs of heart failure, and monitor them with echocardiograms. But generally, we try and keep them on some heart failure therapies. Now, the group that has mildly reduced ejection fraction, the EF 40 to 50%, we tend to treat them like we used to treat heart failure patients 10 years ago. So ACE inhibitors, angiotensin receptor blockers. So they don't quite qualify for Entresto. Heart failure selective beta blockers and mineralocorticoid receptor antagonists. Okay. So this brings me to the part of the talk where I'll talk a little bit about HFpEF. And HFpEF and HFrEF, so reduced ejection fraction, preserved ejection fraction, are quite different. So in HFpEF, the ejection fraction is normal. It's more than 50%. The left ventricle usually looks completely different to someone with HFrEF. They tend to have smaller ventricles that are concentrically remodeled. What that means is that the walls are essentially chunky, that there is increased relative wall thickness relative to the internal dimension of the left ventricle. And these patients tend to have normal LV volumes. And that's quite different to patients that have HFrEF, where the ejection fraction is less than 40%. They tend to have eccentric remodeling or eccentric hypertrophy. So the relative wall thickness is normal. So normal wall thickness, but the ventricle dilates. Now, in HFpEF, the main thing or the main feature is we've got this normal size heart that's chunky or concentrically remodeled, and it's a stiff heart, so there's diastolic dysfunction. So what we might see is that the patients on their echo have dilated atria, and that's due to the chronically elevated left atrial pressure. And it's quite rare, not unheard of, but it's quite rare for them to have normal size atria. That we might see parameters on the echo report that point to elevated left atrial pressure, or elevated left ventricular pressure. Thing we might see in the report is an elevated E on E prime, for example, and they might have elevated pulmonary artery pressures as well. So HFpEF can be quite a challenging diagnosis. And we need to remember that it's a specific clinical syndrome. So it's not just the patient that has diastolic dysfunction on the echo. It's a patient that has symptoms and signs of heart failure, and they have a normal EF, and they have evidence of diastolic dysfunction on their echo with elevated filling pressures, either at rest or elevated filling pressures with provocation, so with some kind of stress. And even though it's a tricky diagnosis to make, it's quite common. It accounts for about 50% of heart failure patients, and it still carries a high morbidity and mortality. And it tends to be associated with comorbidities like getting older, obesity, hypertension, coronary artery disease, kidney disease, AF, sleep apnea, and diabetes. So I've already said that it is a clinical syndrome. The patient needs to have symptoms and signs of heart failure. So diastolic dysfunction alone on an echocardiogram doesn't mean the patient has HFpEF. The two are not synonymous. So diastolic dysfunction is a quite normal part of aging, and it is seen in many people that do not have and will likely never have heart failure. So a patient can have impaired diastology without HFpEF, and a patient can even have on an echo report elevated filling pressures, left atrial pressures or left ventricular pressures, and not have HFpEF. So in order to have HFpEF, you need to have heart failure symptoms and signs, and then all those other things such as a normal ejection fraction, diastolic dysfunction, elevated filling pressures. So although HFpEF is predominantly heart failure, as we used to call it diastolic dysfunction, although ejection fraction is normal, patients with HFpEF still usually have some evidence of systolic dysfunction, even though the EF is normal. We need to remember that EF is only one marker of systolic function. It's a fairly crude marker of systolic function as well. And there are many other things that, that can be markers of reduced systolic function. So we often do see in patients with HFpEF that they might have abnormal strain or reduced long axis function. So that's something that like tissue Doppler velocities that we might be looking at on echocardiogram. Other things that we might see on an echo in a patient with HFpEF, as I said, they often have dilated atria. 2/3 of HFpEF patients have elevated pulmonary pressures on their echo. About 1/3 have some degree of RV dysfunction, and about 50% have atrial fibrillation. So it's thought that endothelial dysfunction is one of the central things in HFpEF, and that those risk factors, obesity, getting older, leading a sedentary lifestyle, insulin resistance, hypertension, and thought that those things contribute to a pro-inflammatory state that leads to the endothelial dysfunction and microcirculatory dysfunction and myocyte hypertrophy that's seen in HFpEF. So as a cardiologist, when I'm seeing a patient with heart failure, making the diagnosis of HFpEF, I'm usually looking at them clinically and looking at their echo parameters. However, there are some HFpEF scoring systems as well that can be used. And we look at things like their BMI, if they've got difficult to control blood pressure, their AF, their pulmonary pressures, their age, and filling pressure parameters on their echo. And if the patient scores more than 6 on this particular scoring scale, it's likely HFpEF. Scores less than 2 means unlikely HFpEF, and the ones in the middle means indeterminate, and we need further testing. So diagnosing can be difficult because sometimes we might not have evidence of elevated filling pressures on their baseline echo, and that means that we need to do some sort of provocation testing, and that can either be a stress echo, basically to assess their diastolic function after they've exercised, and we can also do invasive testing to make a diagnosis of HFpEF, and that's the gold standard, but it's not routinely done, and there's only one centre in Melbourne, which is the Alfred, that does exercise right heart caths, and that what we tend to see in those situations, if a patient has HFpEF, is that their wedge pressure goes up with exercise. So HFpEF is a specific diagnosis, and just because somebody has a normal EF and heart failure, it doesn't necessarily mean HFpEF. So a person might present with symptoms of heart failure or fluid overload because of other things such as valve disease or restrictive cardiomyopathy, amyloid, pericardial disease, right heart failure, LVOT obstruction, etc. And these are different conditions that have their own specific treatments and are different to HFpEF. So we need to keep those things in mind as well. So the treatment in HFpEF is focusing on getting the patient euvolemic, so decongestion, and there's less evidence for guideline-directed medical therapy. And the 4 classes of drugs that we use in HFrEF don't necessarily have the same evidence for HFpEF. So the ones that do have some evidence and that we do use in our HFpEF patients are the SGLT2 inhibitors. There's been some evidence that it reduces heart failure, hospitalizations, maybe some reduction in mortality, and the mineralocorticoid receptor antagonists such as spironolactone. And then there's less evidence for things like ACE inhibitors, angiotensin receptor blockers, or ARNIs. The main focus, however, is treating the contributing factors. So if obesity is an issue, then weight loss therapy should be a focus. Treating hypertension, treating their AF, investigating for and treating obstructive sleep apnea, treating their diabetes, their coronary disease, and promoting a healthy diet and regular exercise. So when should we refer a patient on to cardiology? Well, all patients that have HFrEF should be referred on to a cardiologist. So we have a heart failure specific clinic at Western Health, and you can refer to your heart failure patients and to the heart failure clinic. The most important thing to attach to that referral is the echo report. So we need to have an up-to-date echo. And we also want a bit of clinical detail as well in terms of, how symptomatic the patient is so that we can triage appropriately. Now, the details on how to refer to Western Health Heart Failure, you can find it on the Western Health internet page. So we will see all patients that have reduced ejection fractions, and we will see all cardiomyopathies as well. So the hypertrophics, the infiltrative, restrictive, ARVC, chemotherapy related, etc. When it comes to HFpEF, we tend to see only those refractory cases. So those patients that remain symptomatic despite trialing maximum tolerated doses of diuretics and management of those other risk factors that we've spoken about as well. Otherwise, in the initial stages, they tend to be managed by general cardiology clinic. Okay. I'll just skip through this, and I'm going to hand over now to our heart failure nurse, Karis, and she will talk a little bit about a project that we're involved in at Western Health. We would really love some GP involvement, and we'll provide, and Karis will provide some information on what we're doing, and our contact details if any GPs are wanting to be involved. So I'll hand over to Karis.
Thanks, Stav. So SafeHF is a project that has recently started operating through Western Health. It's also currently running at Eastern Health, Austin Health, and soon Monash Health. And it stands for Translating Heart Failure Guidelines into Practice and RCT of a Nurse Practitioner Service. So essentially the crux of this program is to explore the benefit of a nurse practitioner-led service in the patient's GP clinic in relation to improving their heart failure therapy uptitration with the goal of reducing their risk of admission, or if they've just been discharged from hospital, to reduce their risk of readmission. So as Stav has outlined, we know that heart failure management is complex and often encompasses non-pharmacological strategies. We've seen multiple drug classes and intervention-based approaches with treating heart failure. And the national data suggests that more than 150,000 people with heart failure are hospitalised annually in Australia. And we know, broadly speaking, that in general practice, the uptitration of medical therapies is much lower than we would like. And obviously that's largely dictated by a very short time constraint that GPs have with patients, and you're trying to make quick decisions in a short amount of time. So this program recognises that primary care for patients is the cornerstone of heart failure management, and we want to assess whether it can be enhanced by a heart failure specialist service that includes a heart failure nurse practitioner within the patient's GP. So the original goal was to recruit 1,200 heart failure patients from the 4 health services that I've outlined. And essentially we've got an intervention group and a control group. So the intervention group is a structured evidence-based management in primary care by the heart failure nurse practitioner. In this case at Western Health, that's me, GP and primary care nurse in a co-consulting arrangement. And patients who are randomised to the intervention group are able to be seen in the GP clinic for weekly, if necessary, for up to 12 weeks post their enrolment, and this is at the discretion of myself or maybe the GP as well in working together. So patients don't need to be seen weekly. If, for example, we see someone, so everyone needs to be seen within a week of discharge, but then if they're reasonably stable and we want to give them a couple of weeks of trialing up titration, get some bloods done, then it might be that we see them again at week 3 or 4. So it's really just the protocol for this project allows patients to be seen weekly if needed for up to 12 weeks. So as part of that intervention group as well, there's surveys for patients to understand their impacts of their heart failure on their quality of life, as well as their health literacy levels, etc. So all of that is included for both groups. So then the control group is usual care, which is organised by the hospital and GP. And so it's just to emphasise that with the intervention group, there's no treatment offerings or care offerings that are removed. It's purely layering this project on top of what a patient may already be attending. So their cardiologists, whether they've got community care, COs or racer clinic, this is in addition to their usual care. And then the control group is only usual care. And so as I've sort of outlined, we want to really assess whether having a nurse practitioner model in the patient's primary care is a way of improving adherence to and increasing up titration and adherence to the guidelines, and essentially just testing a new model of care and whether this is something that could be rolled out longer term. And we're wanting to look at the two groups in relation to, does the nurse practitioner model assist in reducing hospitalizations and mortality, improving quality of life, and in giving patients the tools to improve their self-awareness of their condition, as well as to provide a return on the investment. So this was a project that's been funded by the HFmrEF, and so it's part of an extensive program that's operating within Victoria. I do want to point out that if you're a GP that is interested in participating, firstly, I would love to hear from you. And so there's a QR code there that I will give you opportunity to scan. You can do that anytime, and it will just come through to me with your details and I'll follow up with you. But I do want to emphasize as well that if you're a GP and you're part of a big medical group, you don't need the approval of head office from that medical group to participate. If you're a GP and you're treating patients with heart failure, you have the ability to sign up as a GP so that if patients are admitted to Western Health, then you can notify me or I can track back to you and explore randomizing the patient should they agree. So you can participate in the program as a group of GPs within your whole practice if that works for you, but also you can work as a single GP if the other GPs in your clinic are not interested in participating in the program. That's fine too. So just to make that clear, but I would love if you want to take a minute you can scan the QR code, and simply that's asking for your name and your practice name and a contact so that I can follow up with you in the next week or two to discuss the program further with you. So you're not committing to anything, and it's really just to have further conversations about the project. So yeah, we're really excited. We've had some really great feedback already about the project, as have the other sites. We have across Victoria at the moment between 50 and 60 GPs in the metro services, GP clinics that are participating. And so we're just really hoping to expand the program and I think it's a really valuable service for patients. So please take a minute to scan the QR code and let me know if you're interested. That'd be great. And I'll hand back over to Stav or Joe.
So just to clarify, that means that GPs can refer their patients onto us to be part of the Safe Heart Failure program. And that will involve, if they're randomized to the treatment arm, to be seen by yourself, Karis, at the GP's office for education and uptitration of medications 1 week post-enrollment and for up to 12 weeks, as many times as they need to be seen in that period.
Yeah, correct. So originally the program was for patients who had only been admitted to hospital, but we can now accept patients through the GP. So if you're particularly, or from the GP, so if you're particularly interested in referring, that'd be great. And then we can come and speak with you and talk more about what that looks like. But it's a very simple referral pathway back to me. And yeah, then there's essentially the same structure of the program exists. So if you have a patient that you're concerned might be at risk of presenting to hospital, you can refer to the program as a participating GP, and I will then randomize them, if the patient consents to the program, either to the intervention group or to the control group. And then depending on that, I would notify you in relation to which group they've been randomized to, and work with your practice manager and your practice team from there. So just there's no requirement for me to access any of your in-house medical director or best practice management programs. I simply just need a room essentially to see patients, and then I've got the opportunity to see them on my own, and we can also then tag that onto an appointment with you guys as GPs, or if need be, we can do a co-consult model where we actually see them in the same room together. So there's kind of a lot of flexibility in relation to what might work for the patient, as well as what's going to work for your practice and your systems.
Okay.
Karis, can I just ask if we've had a patient who's been admitted and that the GP may not have been aware that they had some heart failure and they have an acute admission. While they're on the ward, are you going to contact the GPs and say you've got a patient here and are they interested in participating? How are you going to manage that?
So I'm kind of doing initial stages of contacting lots of clinics, and so there's been a lot of clinics that have had information sent to their practice managers. So yeah, if I identify a patient that I think will be really good for the program, then I will contact the GP, even if they're not familiar with the program, to try and recruit them that way as well. So yeah, I try and grab patients from all angles, whether the GP refers to me or whether I then try and engage the GP when the patient's in hospital. Correct.
Thank you. Did anybody have any questions? I think we've had fantastic presentations from Stav and Karis about an update on the heart failure and all the new treatments and and the services that are available. Stav, do you know what the wait is for heart failure clinic at the moment? Because I know some of our clinics are overloaded and others aren't.
So it varies. We do have a wait list even for our patients that have just been in hospital and we're discharging them. The majority will be waiting 3 months for an appointment. I do all the triaging, and so if there is someone that is urgent and needs to be seen, I will make sure they're seen. So that's why it's quite important on the referrals from the GPs that we know what the person's clinical state is right now. Are they deteriorating in the community? So I can make the assessment of how urgently they need to be seen. If they've been triaged and something happens in the meantime and they are deteriorating, the GP can always reach out again so that we can re-triage, but it's quite important we have all the information. So for our post-discharge patients, we try and get them to our racer clinic as a sort of bridge between them seeing us in cardiology clinic. The general wait for all other is about 3 months. Could be more, yeah. But if someone is truly urgent, so if I get a referral that says pregnant woman, breathless, echo done, EF 40, they're going to be seen within the week. So, yeah.
And if GPs want some advice, you know, the phone a friend advice, who should they call?
So the cardiology registrar on call who's taken referrals is probably the first person to call if they need some advice. And if it is a heart failure specific question, that the cardiology registrar is usually able to provide the majority of advice. And if it's something quite specialised, they reach out to one of the heart failure specialists.
Thank you. And I guess my other thought was, given the risk factors and our population out west, one would think that we're going to see a lot more of this. There has to be lots of it hiding out there that we're going to just see more and more. Is that what we're experiencing at the hospital with increasing demand?
I think so. The numbers in our heart failure clinic, however, haven't risen dramatically over the last few years, but I suspect they will be slowly climbing. Yeah.
And I guess some of this research is going to help us with, you know, evidence helps with our funding of some of these programs. So I think it's really good to have that interaction between the GPs and our heart failure nurses and cardiology teams to try and get that sort of increase in continuity of care across the service, because like everything, we know that the majority of the care is going to need to happen out in the community for these chronic conditions.
Yeah, exactly. And every opportunity we can to uptitrate medical therapy is important to try and utilize it, especially if we have, you know, 3 months wait post-discharge from hospital for the first cardiology review. Then we are relying quite heavily on GPs in the community to try and uptitrate therapies, and sometimes that's not very well conveyed on our discharge summaries, or potentially not well conveyed. But at every opportunity that the patient touches base with a medical practitioner, we should try get them on guideline-directed medical therapy. Yeah.
So I think if that discharge summary isn't clear about uptitrating, then you call the cardiology registrar and try and pin them down and get that advice on what to do. Or if you're not sure, should you do one or the other, then it's probably a good idea to be phoning a friend.
Yeah.
Okay. Does anybody else have any other questions or comments they'd like to make? No. Steph, do you want to just move on to that next slide, because I think it's got our I think it's probably the question one, and then we'll go on to the next one. That's
sorry. There we go.
All right. So I'd really like to thank Stav and Taras for a fantastic session this evening. I think it's provided a really good update and a review of the medication and how to manage out there in the community with these, you know, patients that can be quite challenging. And sometimes you think, you know, you push one thing up and something else goes on, and, you know, it is really quite a tricky balancing act, especially, you know, they're often got other comorbidities, their renal function's terrible, and, you know, there's a whole lot of other social issues and things. So I think they are quite challenging for us to manage in primary care. But I think it's like everything else. The more we see, the more comfortable we're going to get. with uptitrating the medication and fiddling a little bit. So I think it's going to be one of those situations. So I think if we'll finish up now, important that everybody can provide their feedback. So as you can tell us what worked, what didn't work, what you would like to hear more about, so as we can start to plan our sessions for next year. We do have a upcoming session on endometriosis next week, so completely different. For those GPs who are shared care maternity providers, then we will have our workshops in September, so that email will be coming out. And then we've got a couple of diabetes sessions October, I think. So, you know, and then the year's sort of almost finished, and people will have had education overload. So, but I am starting to plan things for next year, so please let me know what you would like to hear. Please tell Yvonne, because the PHN are also planning sessions as well. So Yvonne will follow up with your certificates and CPD. I can still see a few iPhones and funny registrations there, so I hope Yvonne sorted everybody out. So yeah, so thank you, and you will receive the email from Yvonne in the next few days. So thank you, everybody.